Good morning. I'm Dr. Robin Cohen from the USC School of Medicine. I'm also the chairman of the Workforce for Media Communications. Welcome to our annual press conference and welcome to the STS annual meeting. Our next paper is entitled Reusing Patients' Own Blood During Heart Surgery May Improve Outcomes and will be delivered by Dr. Eric Zimmerman from the Oregon Health Science University in Portland.
Thank you. It's a pleasure to be here. So I was at New York Presbyterian Queens when I undertook this study. I've since taken a research position, taking a 2-year sabbatical from my general surgery training to pursue research. But first I'd like to start off by saying this is not a new concept. It's something that we're advocating heavily for because of the results that we've seen. And B, I think a good place to start is with a little bit of historical perspective. Sometimes by studying what we've done in the past can give us clues as to how we can make improvements in the future. Specifically, I wanted to talk about cardiopulmonary bypass. I don't want to get too much into too many technical details, but on the left we have the Mayo Gibbons oxygenator, or heart-lung machine. This was developed in the 1930s, first employed in the 1950s. One of the key limitations of this was there's direct gas-blood interface, which caused some degree of trauma to red blood cells. In some cases, it actually caused direct destruction of those red blood cells. This is further improved with the DeWalt bubble oxygenator, just as it sounds. It used gas bubbling through the blood to elevate it, and as you can see in this helical spiral, it would trickle down through the machine to debubble it. And in recalling some of the stories of serial development or serial evolutions of this, Denton Cooley actually recounts putting things like steel wool in the bubble oxygenator to help eliminate some of the bubbles because that was one of the early problems. However, that problem was ameliorated with the development of the hollow membrane oxygenator, which eliminated the direct contact of the gas with blood and allowed diffusion instead of direct contact. But there's still one problem that remains, and that's the mechanical circulation component of this. Given that we still have to use some sort of mechanical pump, there's still direct trauma caused to the red blood cells and other components of blood. Specifically, it causes direct trauma, it activates platelets, causes increase in inflammatory markers, potentially depletes some of the clotting factors. As we know, cardiac surgery is still one of the biggest consumers of blood products in surgery today. I think that a recent study indicates that cardiac surgery uses up to 20% of all blood products in surgery. Almost half of all cases still require some sort of blood transfusion. This has risen to the level of importance that STS and SCA have advocated for more aggressive blood conservation strategies in 2011. And basically the theory of intraoperative autologous blood donation or acute normal volemic hemodilution is that take off some of the blood, don't expose it to heparin, don't expose it to other drugs intraoperatively, and most importantly, don't expose it to the mechanical circulatory support that causes direct trauma to the blood. There are other approaches that are complementary to this that are currently under investigation, such as hemoadsorption, which can remove some of those inflammatory cytokines via surface adsorptive materials. Similar concept, but I'm only going to present on our findings of the intraoperative autologous blood donation. Our objectives were our primary endpoint was to determine whether we could influence the number of packed red blood cells transfused after surgery. We also looked at total amount of transfusions throughout length of stay in the hospital and a number of patients that required any form of transfusion. It was done as a retrospective study after implementation of a more uniform intraoperative autologous blood donation strategy in 2013. We did this via retrospective review of the electronic medical record, pulling out those patients that underwent cardiac surgery during this period. Initially, there were 1,300 patients. We only got to about 650 for the analysis, and we have 1,000 that we've submitted in the manuscript. I'll be presenting on the 650 included for the purposes of submitting this abstract to STS. We looked at the baseline characteristics to make sure there weren't gross differences. We looked at the outcomes, and we looked at blood product transfusion, length of stay, and other postoperative variables such as chest tube output. Other notable exclusions were emergency cases, life-threatening emergencies, people with massive hemorrhage, or those patients with hematocrit less than 24 prior to surgery. Our goal is to remove at least 400 cc's of autologous blood, store it in the operating room, and return it after cessation of cardiopulmonary bypass and reversal of heparin with protamine. Just to give you some perspective, use of autologous blood preoperatively has been examined before, but that comes with associated costs, specifically the additional tests, the blood banking. But using this method, we just store the blood in the operating room, never leaves the patient, or never leaves sight of the patient. No additional testing is required, no special facilities to store it, just a citrated bag for whole blood. And the baseline characteristics can be seen here. There are a few notable differences. Group 2 was slightly younger. However, it has not been proven that older patients necessarily bleed more. But the types of surgeries were essentially equal across both groups. The thing that we noticed in our analysis was there's an effect on the number of patients required any transfusion. This was statistically significant. The number of units required if a transfusion had to be undertaken. And interestingly, there is also a reduction in the length of stay. We attribute the reduction in length of stay to potentially some of the other covariates that go along with that, such as chest tube output, which you notice is potentially lower here. That can be as a result of less bleeding or having more intact blood to keep the fluids intravascular. If people's chest tubes come out sooner, perhaps they leave the hospital sooner. But in our manuscript that we're submitting, we do analysis on all the postoperative outcomes as well as mortality. No difference across mortality, which at least establishes safety, but we did note that there is a reduction in some complications. But most specifically, we were aiming at showing that this is an effective strategy at reducing the number of red blood cells that have to be transfused. So again, this is not new, this is not revolutionary, it's more evolutionary. And as we continue to strive for better outcomes, focusing on blood conservation, we think this could be an important component to a blood conservation strategy or outcome improvement process for hospitals. Future directions that we're investigating are trying to get to a scientific basis for why intraoperative autologous blood donation may work, specifically looking at some of the inflammatory factors with flow cytometry, doing functional clotting assays that require prospective, randomized, blinded trial, where we actually bank samples that we apply a little bit more science and rigor to this to, I guess, pull in some of the understandably skeptical observers at this point. And also, this has been done at very large academic institutions in the past. Presbyterian Queens is academic affiliated community hospital. It's not something that you need a lot of resources to do. It just requires buy-in from all departments, the surgeons, the anesthesiologists, the perfusionists. And on that note, I'd really like to thank all those that helped me out with this. Most notably the perfusionists, who kept very good detailed records of the intraoperative fluid balances, talked me through their records, and kind of got me interested in pursuing research. The cardiac anesthesiologists for pulling me into the operating room as a young general surgery intern, explaining cardiovascular physiology, and the cardiac surgeons that operate as instrumental mentors to see an interest and pull me in further and have side discussions and to ultimately encourage me to pursue research in a dedicated fashion outside of general surgery residency. Kind of short and sweet. Any questions?
Very good, thank you. This paper will be discussed by Dr. Gabe Aldea from the University of Washington in Seattle. Dr. Aldea is a well-known authority in avoiding transfusions surrounding heart surgery.
So thank you. It's a privilege to be here and talk about this very important topic. And again, as Dr. Cohen mentioned, we became interested in this problem about more than 2 decades ago, 25 years ago. And at that point, we were very struck by the fact that at least half the patients undergoing complex cardiac surgery still require transfusion. So it's a very common event. And there were two, as Eric mentioned, there were two major reasons for this. One is that there is a dilution of blood cells that occurs with going on a heart-lung machine, and a heart-lung machine is very important to repair complex cardiac issues. And the other is a biological issue when blood, both formed and unformed elements, platelets, red cells, and other components come into contact with the artificial surfaces of the heart-lung machine. There's an activation, as you've heard, and that causes loss of some coagulation factors. And for this, you have to thin the blood with a blood thinner called heparin. We got interested in this problem because the question that we had is, could we decrease the incidence of a transfusion? And we took a very different tack, which is to use new surfaces to decrease the inflammatory response to cardiopulmonary bypass, what's called biocompatible circuits. And to us, a more interesting question was, can we lower the degree of blood thinning that's necessary so some of these things would not happen? And so at that time, we were really investigating how safe that approach was. And we realized that there were ways of doing cardiopulmonary bypass that caused less, that did not require this hemodilution. And not only that, but even with lower blood thinning, we were able to provide very safe perfusion and actually a decrease in the activation of platelets and of formed and unformed blood elements. And one has to remember that teleologically, the coagulation and inflammatory systems are cross-linked in signaling. So when you have coagulation abnormalities, you also have inflammation. So that was sort of really new at the time, but it has been really new since then. But we were able to document at the time that we can decrease transfusions by 50%, which is pretty dramatic, which is what you've shown right here. Very interesting was, to me, was that this wasn't just an experiment in can we decrease transfusion and resource utilization, but when you are doing that, you actually have a dramatic improvement in clinical outcomes. There is a dramatic improvement in the time that the patient is on a breathing machine, in the incidence of atrial fibrillation, which is also a marker of inflammation, and there was also a significant increase a decrease in length of stay of the patient stays both in the ICU and in the hospital. So that was demonstrated to be extremely cost efficient, so you're not only using less resources, but you're actually impacting patients' care. So the question was, why was it such a dramatic importance? And it's interesting because when we developed this required a major change in how one does surgery. You have to be much more attentive to detail, how you do it. And at the time, only a small subset of surgeons adopted some of these techniques. Interestingly, the adoption of this technique led to something completely different, which is the current ECMO circuit, which is used to resuscitate patients with catastrophic pulmonary or cardiac complications because of the same concept of decreasing dilution, having closed circuits, minimal blood-air interfaces. What's gratifying to see in this paper is that any technique that you use to decrease transfusion, and in relationship, this is very simple, and as Eric said, reproducible, causes a dramatic improvement in clinical outcomes. Also interesting that if you look at the amount of chest tube drainage, it doesn't reflect. You don't really see, you see a dramatic improvement beyond what you see as far as bleeding. So somehow the blood elements are more intact, and perhaps by decreasing transfusion of blood components from a blood bank, that results in a very dramatic improvement in clinical outcomes. So from my perspective, and we use this technique now much more commonly, we do it routinely, the question is, why would you not do this technique? Or more importantly, every surgeon does cardiac surgery, what technique or combination techniques are you using to decrease the incidence of blood transfusion? It's not irrelevant to decrease blood transfusion. Now, it might not be cause and effect, but it might be the people that don't need transfusion also do much better because you were able to do the surgery more safely, more effectively, and there is a dramatic improvement in outcomes. So we have seen this very important paper, again, demonstrate a relatively simple, reproducible technique. There were other dramatic experiences earlier in the Chamberlain paper. Just a small incidence of giving platelets for neonates can decrease transfusions dramatically, again, having to do with less activation. And so it's striking to see how every single technique and paper that can reduce transfusion has major clinical impact. And this is aside from the infectious and issues that are related to transfusion. Now the blood banks are really safe, so that's not a major issue. But it's also very dramatic to see less resource utilization, particularly as we're dealing with more complex patient populations. So the other dramatic thing that strikes me in this paper, that we worked very hard to decrease our transfusion rates 20 years ago from 40%, which I thought was extraordinarily high, to 20%. But as you saw from the work that was done, the incidence now is on the order of 60, 70, 80%. Again, patients who come to surgery are commonly on blood thinners because, again, if they had a coronary intervention or if they had other procedures, it's a life-saving, life-enhancing thing to give drugs that impact coagulation system. They might be sicker, more anemic, and so forth. So it's even more important to apply these techniques to the current patient population. So just as a comment to, or a question to Eric is, why just this technique? What combinations of techniques do you use? And are there any patients that you would not use this in?
Thank you for the welcome question. One thing that's also been studied is, not by our institution, but by others, is reduction of the circuit length. Less circulating blood in the machine leads to less hemodilution. Also, retrograde autologous priming of the pump, again, leads to lower hemodilution. But the question as to why would one not do this? If a patient is baseline anemic on admission prior to their surgery, they wouldn't tolerate taking blood off. That would be an important caveat. But that's the question that I came here to ask, is can we make this a more standard practice, and can it receive a higher degree of adoption across institutions? One important paper that was presented at STS 4 years ago, it was a prospective perfusion database, but they looked at acute normal volemic hemodilution, same thing by a different name as IID. And they noticed that there's only a 14% utilization rate across 15,000 cases. So that speaks to me that people know about this and they know it works, but there's still some variability. And that's a question that I think would really advance the field a little bit in standardizing things.
Are there any questions? Yes.
Hi, my name is Yael Maxwell with TCTMD. I have 2 questions. Thank you. Hi, my name is Yael Maxwell with TCTMD, and I have 2 questions. The first one is, would you do this with any cardiac surgery? And the second one, which you've kind of hinted to, but what are kind of the biggest barriers that people say, I don't do this? Is it just a behavioral thing, or is there costs associated or anything like that?
So first question. This was, as far as I understand, based on what I've looked at in the literature, This is the first time that an institution has said, we're going to take all comers, all types of surgery, unless their blood level's too low, or it's a life-threatening type surgery where you can't spare taking off any blood. So we strove for 100% adherence rate. We met 97% adherence rate. And that was, it's a policy that, it's a technique that we were using prior to the implementation of our new policy, but there's only about a 20% utilization rate prior to that. So it's as much an exercise in change culture as it is applying a particular technique. And just anecdotally talking to the perfusionist, the anesthesiologist at my hospital, and in fact, that's kind of what got me started on this whole track is just being present in the operating room, being a new set of eyes with a naive view of things and just asking questions. Part of the reason I got into medicine is because of some books that Atul Gawande wrote. In Better, he says that if you notice something, start counting it. And unless you count something and make a measurement, you can't bend the arc at all. So that's, in talking to the anesthesiologist, it was another piece of work that they had to do. And they were kind of equivocal or ambivalent perhaps about whether it actually worked. So unless we put the science out there and we put the rigor in to actually demonstrate efficacy, we won't get buy-in. And getting everybody on the same page, and which is sometimes getting everybody in the same room to talk about what their concerns are. For the perfusionist, it meant keeping track of another number and potentially running a little bit closer to the red line of comfort, if you will. But there are just tiny incremental changes we can make, and that requires, I hate to harp on it, but interdisciplinary cooperation. Teamwork is what really makes this happen.
Can I just add something to it? So I totally agree that it requires a culture change. So in the past, there are a lot of things that we as physicians or perfusionists or anesthesiologists that we understand that the risk to this procedure is usually the patient and the status. And with education and a collaborative approach, because it really takes everybody's efforts to make most patients, this is not something that should be applied to a small segment of people, but blood conservation should be thought through for every individual that reaches the operating room. So that requires, so again, it's a combination of techniques. Can you decrease the amount of non-blood elements or hemodilution by decreasing extraneous fluid or ultrafiltrating? Can you save the patient's, a segment of the patient's blood to have more functional blood elements? Can you decrease bleeding during surgery? And so part of it requires time to really get the patient ready before you go on a heart-lung machine. So that takes efforts with anesthesiologists perhaps giving some more medicines to allow for this, taking time to do those maneuvers, which takes some physical time, typically under 15 minutes. So there is an element of just getting things done, but on the other hand, if you're really able to accomplish this, and in my experience, when a team focuses on an outcome, that by itself changes the outcome, because as you said, when you look at a number, usually things get better, and then maintaining that focus, which is something else that is required over time. So it's doable, it's something that's broadly applicable, it has no downside to it, and I think that it could be applied to most patients, even some of the patients that are going for urgent surgery, if one is giving it sufficient time.
Other questions? So I've been a proponent of this technique for some time, and I think it's important to emphasize that it eliminates the inconvenience and cost associated with the blood bank, and the product that you're giving back by virtue of the fact that it's fresh and whole blood is better than anything that you can get from the blood bank. My question is, as I was trying to think of the risks, the only things that I could think of are the remote chance of a citrate reaction from the preservative in the blood, a remote chance of infection, and a small chance of hemodynamic instability when you're taking the blood off. Is that right? And are there any other risks associated with this technique?
I haven't observed that in our data set, so I probably don't have a large enough data set to detect that. But
What do you think, Gabe?
We haven't seen it, and again, it just takes time. So particularly if you're combining elements, if you're using this technique, then decreasing the prime has to be even more thoughtful because they're sort of complementary. So it might require a little bit of timing of how you do this. The other is, as you know, when you give cardioplegia, you're giving a lot of crystalloid, particularly now with the new and improved Del Nido composition. So hemofiltration is another component of decreasing dilution. So I think it's a matter of having a plan of how sequentially to implement those things. And so I think if one is dedicated to it, it just takes a little bit more patience. It might require some more vasoactive drugs at the beginning of the procedure to do that. But I haven't, the concerns that you have, which are significant complications, we haven't seen any. And so I think this is broadly applicable. And this is just one more positive study in a series of positive studies. So it just tells us that the concept itself is very sound. How you get there are 3 or 4 or 5 ways. My suggestion is you typically want to use more than just one, but you start with one and you become familiar, and then you can add some others as the team becomes more sophisticated and focused on this outcome, because some of the concerns about causing instability, it's just a matter of experience, and some of these, it's just a matter of comfort, as somebody mentioned. I think you mentioned comfort for the perfusionist of doing this routinely. And it really makes a big difference for patients, and I think some of the patients, some of the higher risk groups of patients, the more unstable patients, may actually benefit just as much. The other way of thinking about it is if somebody is really truly anemic, we haven't looked at the reverse part, which is what can you do, and there are many researchers working on that problem. How can we decrease the anemia aspect when a patient comes to surgery? Are there some things we can do beforehand so more patients can be candidates for these sort of therapies and be able to really get to a much lower rate, perhaps a very small fraction of patients undergoing bypass that would require blood transfusions?
Thank you very much.
Thank you.